For this section of the video, we're going to discuss pacing. Now, pacing is a bit different from the defibrillation and the cardioversion that we discussed earlier. And essentially what pacing does, it augments the patient's heart rate to a rhythm that then allows perfusion through the patient's body. So the indication for pacing is a bradycardia, so essentially normally heart rate is less than 50, in a patient who has clinical features of shock, things like altered mental status, chest pain, shortness of breath, and hypotension. So if a patient presents with a very low heart rate, okay, below 50, and they have clinical features of shock like hypotension, shortness of breath, altered mental status, and clinical features such as shock, then they are an ideal candidate for pacing. Now, with the new guidelines, resuscitation guidelines, then you have two options to either give drugs like adrenaline or inotropic and chronotropic drugs that would augment the patient's heart rate, or you can use a pacing machine, which is usually a function that's part of your defibrillator. So before anything else, you need to confirm if the defibrillator that you have in your hospital or facility has a pacing function, as this does not come standard in most defibrillators. So always confirm that if you're having a defibrillator, that it has pacing function to allow you to pace a patient. Now, the procedure I'm going to describe again is available in the emergency care algorithms and also available in the Casualty app, which you can download freely from the Play Store, and we'll take you through the step-by-step guide on how to pace a patient. So we have our patient here. Now, the other difference compared to defibrillation and cardioversion is pacing is only possible using pads, okay? You cannot pace a patient using the paddles. You have to use pads because the machine needs to read the patient's own rhythm and then provide a pacing rhythm to the patient at the same time. So you can't do that with pads. So paddles are good. You can do that with paddles. Paddles are good for defibrillation, cardioversion, but for pacing, you definitely need to have pads available. All right. So we have our patient, okay, who's coming to the department. So before anything else, I've connected him to the monitor with the leads off the patient's chest. So I just switch on the monitor to just see what rhythm we're dealing with. Okay, so as mentioned, I'll have the patient on lead 2. As I can see, my patient's heart rate is extremely slow. At this point, my patient has a heart rate of, it's currently measuring, right, 38. Okay, so my patient's heart rate is extremely low. And at this point, it's very good to get a rhythm strip from the monitor, or again, get a 12-lead ECG if possible to see what's the underlying rhythm, okay? So I know you had the ECG sessions before that discusses the different types of ECGs. But the key important part in this discussion here is that the rhythm is extremely slow and the patient has clinical features of shock, altered mental status, chest pain, essentially features suggestive of poor perfusion in the patient. You don't need to have all of them, just one of them that suggests he's not perfusing very well. And again, like we did with the tachycardia algorithm, in the bradycardia algorithm, you have to quickly consider, could it be an electrolyte or metabolic problem that can be easily reversed? Things like hyperkalemia, again, if a patient has, and a lot of this you can pick up from history or do a quick blood gas for the patient and consider other potential reasons why the patient's heart rate other than a primary cardiac problem. But if you cannot identify any other rhythm, then of course, then you should assume it's a primary cardiac problem, in which case, again, your patient will need to be paced. Now, again, like cardioversion, in pacing, your patient is awake and they're alive, okay? And you're about to pass electricity through their heart. So you need to make sure you give them adequate or just enough analgesia and a bit of sedation, and explain the procedure to the patient, because it's quite a painful procedure and you want your patient to be able to tolerate the procedure initially. And once the patient's BPs are up, then you can top up on the analgesia and keep them comfortable. Now, the other thing I want to mention is once you start pacing a patient, you normally will not stop pacing the patient unless you're a cardiologist who then will do all the cardiology things that they do. So as an emergency care provider, once you start pacing a patient, do not stop pacing the patient at any point. The cardiologist will normally take over the pacing. So the first thing, of course, I have my patient, I've confirmed the rhythm, I have ruled out any potential metabolic or electrolyte causes that could be causing this low heart rate. So I have determined my patient's blood pressure is a bit low. So what I'm gonna do is I'm gonna initiate them on pacing. Okay. So the first thing is I want to connect my patient to pads. Okay. So I will connect my patient to the pads. Okay. So this is the same cable we're using earlier to test the machine. So the patient is connected to pads. Okay. So the next thing I'm going to do is switch to pacer mode. Okay. So I switch on and you will see immediately I turn on to the pacer mode. A whole new menu will appear on the screen. So I've switched on pacer and I have a whole new menu that have shown up. Now, it's rare, we don't pace patients that much in the emergency care setting, and we tend to forget how to pace. And the easiest way to remember is ideally you will follow the buttons as they are arranged on the screen or on your machine. But again, as I said, always just quickly get the algorithms out or the casualty app out. The procedure is well explained in that in the two areas. So I will just follow my buttons as they are arranged. So I'll see I can see pausing, paused, and the first thing it says is start pacing. Okay, so I will start pacing. Okay. All right. So the moment I started pacing, I noticed something. You can note we have the markers on the R-wave that were there also with cardioversion, but now we actually have pacing spikes. So these pacing spikes are essentially the machine sending electrical activity to the heart. So remember, in a bradycardia, the heart rate is extremely slow. Okay. So the heart rate is normally extremely slow. Okay, so I'm just going to reduce that because I want to conserve a bit of our paper. And what you want to do is take over the SA node function in terms of generating rhythm using pace spikes being delivered by the pacing machine, okay, or the defibrillator in this case. All right, so I've started pacing. I can see my pacing spikes. Now I'm going to determine what rate. My patient's heart rate is 38. 38 is too low. Okay, remember in terms of perfusion, you need good heart rate and good stroke volume. I know my patient is not hypovolemic for any reason, but the heart rate is a bit low. So I'm going to start at a rate that's comfortable and more or less what we normally are used for. So I'll press the pacer rate and we'll start at 70 beats per minute. Okay, so once I have the pacer rate set, the next thing I'm going to do is go to my pacer output. Now, pacer output is energy being delivered into the patient, and we want to deliver enough energy to stimulate what we call response on the patient. So for every pacing spike, I want to see a wide QRS next to it. So that essentially means the electricity is going to the heart and is stimulating a beat on the patient's heart, an electrical beat. Let me put it that way, so that because I'll need to clarify this a bit later. So every pacing spike must be followed by an electrical beat. Right now we have the pacing spike but no beat. Okay, and the two are independent of each other. So I'm going to increase my output and we'll just increase it slowly. Okay, so I'm at 35 now. I'm at 40. Every spike must be followed by a wide QRS complex. I go up. I go up. All right. We've already provided analgesia and sedation for my patient because at this point the patient's going ouch, ouch. Okay. I'm going up. I'm going up. So ideally I just want to see a spike and a wide QRS next to it, and perfect. There we go. Okay. All right. In this I can see for every spike there's a wide QRS. For every spike there's a wide QRS. For every spike there's a wide QRS. Okay. So that means essentially every spike is followed by a wide QRS complex, and meaning I have what we call electrical capture. Now you will also note my heart rate has moved from 38 to 70, which is what I had set earlier. Okay, so from a machine perspective, I have what we call electrical capture, meaning every spike is followed by a wide QRS complex. Now I need to confirm what I'm seeing here is exactly what's happening on the patient. Okay, so and I will feel the femoral pulse. I don't want to feel the carotid pulse because your patient sometimes is twitching at potentially 70 twitches per minute because that's what you set. Okay, and that's why it's important to give some analgesia and some sedation for the patient. Okay, so I will and I don't want to confuse patient's twitches with the pulse. So I'll check a femoral pulse. Normally I'll check the right femoral pulse, and I should feel the pulse, the same pulse. If I'm seeing 70 here, I should feel 70 beats per minute on the femoral pulse. I see 70 there, I feel 70 here. All right. So that's mechanical capture. So I have electrical capture, I have mechanical capture. Now, the third capture that we have to confirm is what we call physiological capture. So physiological capture is to make sure that, are we now perfusing? So I will check my patient's blood pressure. Okay, has it gone up? Are they now feeling a bit nicely warm perfused? Are they more alert for potentially if that was if the hypotension was causing altered mental status? So the main reason I started pacing the patient was because patient had features of shock. Now, physiological capture is to confirm that these features have now improved and the patient is much better. So I have three captures: electrical capture, mechanical capture, and physiological capture. Once I have confirmed my three captures, okay, remember, this is a minimum. I got the pacer output at 70 milliamperes on this patient. So this is the minimum electricity that will give me capture. If I drop below 70, I may lose capture. So what I want to do is I want to go up, provide a safety margin. Okay, so normally it go 10%, which is in this case would be 7, but the machine only goes up by 10, so I'll go to 80 milliamperes. Now, my patient is being paced. Okay, I have confirmed I have electrical capture, I have mechanical capture, and the patient is now feeling a bit better. The blood pressure is coming up. Well, he's well perfused, he's stable. All right, so I have physiological capture, and then I put a safety margin. Now, there's only one more thing that I want us to discuss in terms of, on the screen you can see it says demand mode. Now, there are two forms of pacing modes. There is demand mode and there is fixed mode. Okay, and the one, as the word suggests, demand mode means the machine will pace on demand, okay, when the patient needs it. And on fixed mode, the machine will pace continuously. Okay, and the difference is, if a patient's initial heart rate was 38, if the patient's heart rate improves by itself and you're on demand mode, the patient's heart rate will, the machine will go on to standby mode, waiting for the patient's heart rate to go below what you had set, which is 70 beats per minute. Okay, I repeat that again. Currently, we are pacing the patient at 70 beats per minute. In demand mode, if the patient's heart rate automatically improves and maybe becomes 75, okay, then the machine, I'll just do that artificially, potentially, and you should be able to see on the screen what happens. I will artificially increase my patient's heart rate. Okay, I don't know that I'll be able to simulate this with this, but if the patient's heart rate goes above what you've set, then in that particular case, then you will not be able, the machine will go into a standby mode. Now, in the emergency department, okay, in the emergency department, we'll normally use, or emergency care services, we'll normally use fixed mode. Okay, why? So, and I'll go here, pacer mode, it tells me pacer mode, and I'll put fixed. And you can see now it reads fixed mode. Okay, why do we use fixed mode in emergency care services? Now, in the emergency setting, our patient is temporarily there with us. In which situation that means we'll be moving the patient either from the emergency department to the coronary care unit, or we'll be moving the patient in an ambulance. And in that situation, monitoring the patient becomes a bit hard to make sure that the machine is constantly pacing, or the bumps, especially where you have potholes and you have holes on the corridor and the bumping of the stretcher, the machine could easily pick up that and say that's the patient's heart rate and go into standby mode. Like I said before, once we start pacing, you do not, in an emergency care setting, you do not stop pacing. So you don't want any situation where the machine will stop pacing the patient, because essentially when that happens, the patient will go back to where they initially were, and sometimes they'll go even further down into hypotension and may end up even in an arrest situation. So in a fixed mode, the machine will deliver the electricity consistently, regardless of what the patient's heart rate is. If the patient's heart rate goes maybe to 75, the machine will still pace the patient at 70. It will not go into a standby mode. In demand mode, if the patient's heart rate goes above what you set, then the machine will go into a standby mode, waiting for the heart rate to drop below what you set. But in the emergency care setting, you want to be on fixed mode. All right. Now, in what setting do you want to be on demand mode? In a patient who's admitted maybe in a critical care unit or coronary care unit where they're just resting on the bed, there's no one moving them around, then in that case, then you probably, it's a good idea to have them on demand mode, in which case, then the machine can go into a standby mode when the patient is, heart rate has gone above what you set. Okay, so in a stable setting where the patient is not going anywhere, but if you were to move this patient anywhere at any point, you must make sure you're on fixed mode. All right. Just a quick troubleshooting in case things are not going as you had planned for. All right. So I'm just going to take us back a bit to where we started from. All right. Okay. As you can see now, we have lost. I've just reduced that to remove electrical capture. Okay. So we will start again. So the process. Again, we've gone through the whole process of indications. Patient is hypotensive, has a low heart rate. There's no metabolic or electrolyte reason they should be having this heart rate. They have features of shock, hypotension, altered mental status, shortness of breath, chest pain. Then in which case, then I won't start pacing the patient. So pacing is already started. Then my heart rate I'm putting at 70. Then my output I'll go to. So as I said, we got capture there. Okay, so I have a pacing spike and a wide QRS complex. Pacing spike and a wide, so every spike is followed by a wide QRS complex. Okay, now I have electrical capture, and I can see my heart rate has gone up to what I had set, which is 70. Now if I come here and check for a pulse, and I'm not feeling, my pulse is still at 38 on the patient's groin. Okay, so over there on the monitor I have electrical capture at 70 beats per minute. But when I check for mechanical capture, I am not feeling a heartbeat at the same rate. So it's probably still at 38. What do I do next? Okay, so essentially that means I need to increase the amount of energy going to the patient. Okay, so we were giving at 70, but I cannot get any mechanical capture, in which case I'll go up 75. I can even just go to 80 and check again. And yes, okay, now the pulse is getting up. And my pulse has my mechanical capture has been achieved, electrical capture has been achieved. So in a situation where you have electrical capture but no mechanical capture, then consider increasing the amount of pacer output, essentially the amount of energy being transmitted to the patient, so that you can give that heart that kick required to get your mechanical capture. All right. Now, troubleshooting again. Okay, we had initially gotten capture at 70. So I have electrical capture. Okay, good. Every spike is followed by wide QRS complex. And I feel for the pulse. I'm feeling 70 beats per minute, which is exactly what is on the screen here. I can feel a pulse at 70 beats per minute in the right femoral. So I have electrical capture. I have mechanical capture. Now let me check again. The third capture is the physiological capture. So I'm going to check my patient's blood pressure, but when I check the blood pressure is still low. Okay, I'm getting it at 60/40. Patient has still features of shock. So I have fixed the electricity. I seem to have fixed the beat at 70 beats per minute. So there are the two options. My patient's blood pressure could be low because they're hypovolemic, in which case I will maybe give him a small bolus of fluid. Okay, and maybe at 250 to 500 mLs and check again. Or, so it could either be a volume issue or a rate issue. So sometimes your heart rate at 70 is not achieving that cardiac output that you really want to perfuse the patient. In which case, a bit of fluid, if that's not working, I can increase the rate and maybe go to 80 beats per minute. And then again, still confirm that every spike is followed by a wide QRS complex. And I'm checking my blood pressure again, and my blood pressure has improved. And now I have physiological capture. Electrical capture, mechanical capture, physiological capture, and then now I'll go up by, remember, always go up by 10% as a safety margin, and there. Okay, so good, our patient is being paced. Okay, so good. So this is establishing pacing in our patient. Okay, so remember, key things: indication is bradycardia, heart rate less than 50, hypotension, a patient with features suggestive of shock, which includes hypotension, chest pain, shortness of breath, and then cool clammy skin, another feature suggestive of shock. And then you mainly need to make sure you're going to the pacer mode. Okay, In pacer mode, you want to make sure you're pacing the patient at a fixed rate in the emergency care setting. And then you'll normally follow the buttons as they are arranged, starting, you'll start your pacing, set your rate. Normally we start at 60 to 70 beats per minute, and then increase your output until every spike is followed, every pacer spike is followed by a wide QRS complex, which is what we call electrical capture. Counter check that by feeling the patient's right femoral pulse for what we're calling mechanical capture, and then recheck your patient's vital sign to see if the features of shock have improved, blood pressure is better, and everything, and patient feels a bit better and is perfusing well, which is what you're calling physiological capture. So 3 captures, and then go up by 10% on your pacer output as a safety margin, and have your patient transferred to the nearest cardiologist for them to take over. All right. Now, other thing, maybe one more thing that I can discuss that happens in a situation, especially where EMS are bringing a patient. Remember, I repeat again, if you started pacing, do not stop pacing, okay? Only a cardiologist will stop pacing your patient, because the moment you stop pacing, then your patient's vital signs again will tank, and that may end up in a cardiac arrest situation. So what do you do when the EMS has brought you a patient, they're pacing, and they want to go away with the equipment, okay? So what do you do, okay? The key thing is to hand over, what we call handover pacing. As I explained, download the Casualty app, get the algorithms. This procedure is well explained in there. But the key thing is you want to get your other set of pads, okay? So you cannot disconnect this patient yet. You want to get your other set of pads, and you can attach them. There are multiple options. You can attach them anterior posteriorly, okay, on your patient. And then the machine that came with the patient, put it on demand mode, okay? Put the machine that brought the patient on demand mode. Then in your departmental machine, put it on fixed mode, okay? Put a heart rate higher than what so our patient here is currently at 80 beats per minute. You can put yours at 85 or 90 beats per minute. And then capture the patient on your machine. When you capture the patient on your machine and go through electrical capture, mechanical capture, physiological capture, then this machine is going to go on standby, because the heart rate on your machine is higher than this one, and this one is on demand mode, in which case then you can disconnect the patient, and the EMS guys can go with their machine. So that's what we call handover pacing. Many people don't know how to do this, but do not stop pacing. You can easily transfer the patient to another machine by setting another machine on a higher heart rate and setting the primary machine on demand mode, so that when the new machine takes over and you've confirmed electrical, mechanical, and physiological capture, then this machine goes into a standby mode and you can disconnect the patient safely. All right. Thank you very much. Pretty much that ends our series on mastering the defibrillator. Make sure you catch all the videos in this series to learn how to be an expert in using the defibrillator. Thank you.